So red eye, as you said, is a very common complaint patients have, and they are referred. They come to you because actually the public is very much scared when they have a red eye. Okay, so as doctors, we have to know what is happening in a patient who has a red eye. So it's one of the most common ocular complaints, and initially they will come to a GP or accident and emergency or casualty units, or they may even go to an optometrist. But however much qualified you are, sometimes it is difficult to determine the etiology at the first instance. So don't worry, even if you can't diagnose the patient in the first setting, because it's developing still, it's okay, but you need to know what you should do. So the workup, you should know. And the patients are very much apprehended. They want to know whether they will have loss of vision from this, or whether they will, whether it's contagious, whether other people will get it. So a lot of concerns from the patient side. Whatever it is, if the patient comes with a red eye, the usual history and the examinations as well as visual acuity should be checked. So actually, what is a red eye? So you have the eye and you have the cornea and the sclera. Okay, the conjunctiva is covering the scleral part here. The cornea doesn't have the conjunctiva. Some books may show that, but that's not correct. So the cornea does not have a conjunctiva over it. It's only the sclera that has the conjunctival layer. So red eye is when the usually white part is red. That is the red eye what we refer. But you have also have a red eye reduction in cameras. Have you heard? Yeah, so it's like this. It is the reflection of the light which falls onto the choroid. Then it reflects back. So the blood vessels, they are reflected back. So that is the red eye reduction in cameras. But now in medical, as a doctor, the patients are mainly concerned with the red eye here. So this baby, do you think the baby is normal or abnormal from what you can see? Is this a normal baby or an abnormal with the eyes concerned? Normal. Why do you say so?
It is due to the camera reflection.
Yeah, the red eye reflection is normal, right? So this is called red reflex. This is the normal reflex that we get. How do you do this? It's very important to check that. You have to keep the ophthalmoscope at 1 meter distance and then check this. That is one of the basic investigations that you can do. If the patient is like this, is that normal? If the baby is like that, is that normal or abnormal?
Abnormal.
Why?
Right side is white in color.
Yes, white reflex. So white reflex is an alarming sign in ophthalmology, especially in pediatric ophthalmology. So what are the causes for a white reflex?
Cataract.
Okay, cataract.
Retinoblastoma and corneal opacity increased.
Yes, very good. So the sinister problem that is there is retinoblastoma, right? So any other opacity in the media also can cause a white reflex. So you can get cataract or scars even. You can appear, they may appear as white, okay? So in the vitreous, sometimes, rarely, congenital abnormalities can cause this. So the most common one is cataract. Most dangerous one is retinoblastoma. So you have to immediately refer the patient, however small they are. What is the, okay, retinoblastoma, you know, it's a life-threatening cancer, the commonest cancer in children, commonest eye cancer in children. Then what is the danger of cataract in a child? Yeah. If you don't do the cataract surgery immediately and then make the eye functional, then there is something that can happen.
Reduction in functional development.
Yes, that's right. What do you call that?
Fine motor development.
Yeah, those are there. With regard to the vision also, the vision later on may not be able to develop the vision later, even though all the structural components are normal. So that is called amblyopia, lazy eye. Okay. So as soon as possible, the vision has to be restored in pediatric age group. Otherwise, they can develop amblyopia. Okay. Right. So any patient who has a history of red eye, not only children, adults as well, we have to get the history. The history is very important. From the history, we can get clues. So when there is a red eye, like a detective, you have to get to the diagnosis. So to aid our diagnosis, we have to get all these details. Onset, is it started in one eye or started in both eyes? How did it start? How long it has been? All that, right? Then the location of the redness. Is it unilateral, bilateral, or only in one sector of the eye? That's important. Then whether there is pain and discomfort, foreign body sensation, or there is itching, or there is deep ache. So all that is important to differentiate. The other important thing is whether there is photosensitivity. What is photosensitivity? Yeah.
Difficult to see light.
Yes, difficulty in looking at light. Okay, so the patient has an aversion to light. So there is irritation and pain when exposed to even sunlight. So this pain, it can be gritty in conjunctivitis. Foreign body sensation, even though there is no foreign body, in conjunctivitis sometimes they can get, because of the inflammation, foreign body sensation. Then itching is there in which condition? Allergy. Okay, so allergy, itching is there. Deep ache in what condition? Red eye. And yeah, when there is inflammation like scleritis, so then there is deep ache. Okay, so watering or discharge. Watering can be mostly in viral conjunctivitis. Purulent discharge can be there in bacterial conjunctivitis. Then change in vision. Usually conjunctivitis, not much of blurring, slight blurring, but not significant blurring. But in some of the other conditions, such as glaucoma, there can be blurring. And glaucoma, there can be halos. That is colored lights, colored circles you can see. That is what is called halos, colored halos in acute glaucoma. That also can give rise to a red eye. Then whether there's a contact history of red eye. So conjunctivitis, contagious sometimes. Whether there is any trauma, whether there is any past history of surgery. So endophthalmitis and other things can be there. Then contact lens wear. Contact lenses are considered to be more common to get infections than spectacles. So unless they are careful, they can get infections. So whether they have been using contact lenses. Then previous ocular history, whether surgery was done, whether there was hypermetropia. Why hypermetropia? What condition? In elderly females?
Angle closure glaucoma.
Yes, that's right. Angle closure glaucoma. Okay. Have you all, some of you have done the eye appointment, is it?
Yes, madam.
Okay, very good. Okay. Then upper respiratory tract infection. Sometimes red eye conjunctivitis can be part of a simple upper respiratory tract viral infection. Okay, so we have to get the history. Then past history of autoimmune diseases and past history of fever. What comes with fever, myalgia, red urine, and conjunctivitis associated with working in the field?
Leptospirosis.
Yes, that's right. What are the other autoimmune diseases that can cause eye problems?
Joran syndrome?
Sorry?
Joran.
Yeah. Sjogren's syndrome. Yes, that is dry eye. That's right. Then even rheumatoid arthritis, autoimmune, dry eye can be there. Then thyroiditis and thyroid problems. Then what about myasthenia gravis? Yeah, so there are so many, right? Okay, so examination, you have to examine the whole patient first, then inspect the eye and check the visual acuity. What is pH? Those who did the appointment, you should know. Visual acuity plus pH. The nurses will write it, or the people who check the visual acuity will write visual acuity is this plus pH this. What is pH? Quickly. Pinhole, right? So what is pinhole? Why do you check with the pinhole? Yeah, the pinhole will actually send only the central rays of vision, central rays of light. So then the refractive errors will be eliminated. So therefore, if the patient's vision is poor, but if it improves with pinhole, you can check this on your own also. Look through something and then look through a pinhole. It should be so small. Then if your sight is better, then you probably you're having a refractive error. So the patients who have poor vision, we want to know whether it's a eye condition inside the eye condition or whether it's a refractive error. So we use a pinhole. If the patient's vision improves with pinhole, then definitely there is a refractive component. Okay, right. Then we examine the eyelids, then conjunctiva. What is bulba? Conjunctiva, we have to examine the whole conjunctiva. So this is over the globe, that is bulb conjunctiva. Then palpebral means lids. So under the lids, behind the lids, palpebral conjunctiva. You have to check both. Then cornea. Cornea has to be checked for clarity, whether the cornea is clear, or if it is not clear, if it is opaque, then whether that is due to corneal edema. Then you can stain with fluorescein. There is a special stain, fluorescein, which stains yellow, and that will take up any denuded epithelial areas. If the epithelium is scraped off, then that will show. So epithelial erosions and corneal abrasions will be easily seen by using this fluorescein staining. Okay, with local anesthetic, we can use that. Then the other important thing in red eye patients is anterior chamber depth, whether they are going in for acute angle closure glaucoma. If the anterior chamber depth is low, then we have to suspect whether they are having an angle closure glaucoma. Then pupils shape and reaction to light is important. Funduscopy, back of the eye also we have to check. And then the eye movements. Okay, if the eye movements are reduced in a patient with conjunctivitis, have you all done pediatric appointments? If a baby comes to ENT or general pediatric ward, maybe 3 years or so, if there is conjunctivitis, you have to specially check because they can get preseptal cellulitis, or later on it can develop into orbital cellulitis. So then how do you differentiate? One important feature would be the eye movements are affected in orbital cellulitis, but they are normal in preseptal and conjunctivitis. Okay. If it is orbital cellulitis, then you have to immediately admit and give IV antibiotics, otherwise the life is in danger. Right, so these are some pictures to show you the distribution of conjunctival injection. So tell me what is here the conjunctival, where is the redness? Is it more bulbar or palpebral?
Palpebral.
Palpebral, yes, that's right. Okay, so the circumcorneal injection is not much there, or the perilimbal injection is not there. So this is the limbus, corneoscleral junction. That's fairly clear, whereas the redness is there. Okay. So it can be due to some other reason, conjunctival, subconjunctival bleeding or subconjunctival hemorrhage can be there. So this is also a subconjunctival hemorrhage. Okay, so the whole area is involved. So now look at the pupil and also look at the clarity of the cornea. Okay, so in this one, where do you think the redness is more common? Circumcorneal or circumlimbal or towards the palpebrae? Which area? Here it's slightly whitish, here it's reddish. Okay, so it's more circumcorneal redness. Here it's fairly white comparably, right? Do you agree?
Yes, madam.
Yeah, can you see my cursor?
Yes, madam.
Okay, right. What other thing do you see here? Pupil?
Dilated.
Yes, it's semi-dilated, right? So what is the condition, suspected condition here? Semi-dilated pupil with circumcorneal redness.
Angle closure glaucoma.
Yes, very good. So those are some signs in angle closure glaucoma. So if you check the pressure, that will be high, very high. So you have to treat the patient with medications to reduce the eye pressure and then do a laser procedure to create a communication between the anterior and posterior chambers. Okay, that's for the anterior angle closure glaucoma. Okay, in this one, so as usual, you would look for the conjunctiva, then the cornea, the eyelids. Also, you can see something. This is what is called blepharitis. And here, the cornea is opaque. It can be due to an ulcer even. And the eye is red. Okay, so check for the cornea to find any ulcers. If there are ulcers, the treatment is different. We can check the ulcers by using fluorescein stains. Okay. Right. What is this in the last column, last lower bottom corner on the right side? What area is red here? It's a sectoral redness, right? So it's due to some irritation there. These days, a lot of patients with using computers also come like that. So there is sometimes due to lubrication issues. So it's dry and it gets more and more irritated, right? So sometimes the cause is not known. So we give symptomatic treatment. Okay, but the here it's different. This is, you can see, circumcorneal injection. That is definitely there is some corneal pathology here. So what are the causes? We can have an idea about the causes and then you can see whether those features are there. So in the lids, what are the causes? What is called blepharitis, inflammation of the lids. Then Calasian stye, those are common causes. Conjunctiva, subtarsal foreign bodies, conjunctivitis, infective or otherwise. Then subconjunctival hemorrhage. Then sclera, there is this episcleritis, what you saw earlier, sectoral conjunctival injection, where the pain is very limited, very less, but scleritis is extremely painful so that the patients get up in the morning, early morning hours, patients are woken up. Then cornea, you have to inspect the cornea for any corneal ulcers and foreign bodies. Both can give rise to redness in the conjunctiva. Then anterior chamber, you have to check for cells, because if there is inflammation, they can get inflammatory cells in the anterior chamber. Then acute angle closure, you can check the angle. Okay, so they are some of the causes. So this is blepharitis, inflammation of the lid margin. So they can have lid crusting, redness, telangiectasia, then misdirected lashes. So if you continue to not clean the lids and touch the eye, and because of irritation, you can get styes from outside. They can go and block. So styes and conjunctivitis is common. Okay, and older patients who cannot clean themselves, it's common. Okay, so that is blepharitis. Then dry eye syndrome, as somebody said, Sjogren's syndrome, rheumatoid arthritis, and other connective tissue disorders. Okay, so sometimes the glands are there, but they are not functioning, the meibomian glands. So they can get the calasia, or sometimes the nutritional deficiencies like vitamin A deficiency can cause poor quality tears. So then also they can get redness. Then this is another important thing, subtarsal foreign body. You all should know how to remove this because it's very, very, very painful. So if somebody known to you gets this, before even getting to the hospital, you can evert the lid and see if it is there. If you can see, you can take it out with a sterile, a sterile cotton bud, even you can get it out. Okay, but if the foreign body is on the cornea, we never try to get it out. If it is only in the conjunctiva part, should the public be involved in taking it out. But the doctors should always learn to evert the lid. Even the lay public can do that. Evert the lid after washing your hands and then remove this particle, and then the patient will be relieved. Okay. Then this is internal hordeolum or stye, acute calacian, okay, meibomian gland infection with staphylococcal infection. Then the commonest thing we see is conjunctivitis, can affect any age. Mostly it is the eyes are red. Usually it starts from one side and then quickly gets to the other side, and the eyes are like this. Usually the circumcorneal region is less involved, but the palpebral area is more involved, and there is tearing also, and mucoid tearing, mucoid discharge or purulent discharge, whitish or yellowish discharge can be there in bacterial conjunctivitis. So if you evert the lid and see, you can see papillae or follicles and discharge. Don't worry too much. The eye may appear like this, ballooned out like. We call it chemosis, right? So sometimes due to allergies also, you can rub the eye and cause this, okay? Right, okay, we'll move on. So viral conjunctivitis, we are not going to go into detail. Most commonly adenoviral, and these are 3, 4, 7 are the commonest, okay? You can read on viral conjunctivitis. Bacterial conjunctivitis, again, common causes, Staph aureus, Staph epidermidis, Strep pneumoniae, Haemophilus. So these are the commonest bacteria to cause bacterial conjunctivitis. And these are contagious. Others can get this, okay? So you have to be very clean and put the drops. The treatment is we give eye drops to reduce the inflammation, and antibiotics sometimes to reduce the secondary infection. Then allergic conjunctivitis, usually they have a history of other illnesses like bronchial asthma. Then the symptoms, itching is the main symptom and the most troublesome symptom. Can be there in by both eyes. Watery discharge can come. Sometimes there is edema, so there is chemosis, and they can form like this giant cobblestones like. Okay, so these are the calcium, these are actually giant papillae, right? Giant papillae reactions due to allergic conjunctivitis. So sometimes we don't know who is causing this allergy. Somebody quite close can be causing the problem. So ask for the history and pet history also. Okay. Right. Then spontaneous subconjunctival hemorrhage. This is also something common. Patients are very much frightened about this because they don't know what is the reason for that. So when patients come like this, you check for the other features. There is no conjunctival edema here or inflammation. So it's only limited to this area. And this can be sometimes due to spontaneous rupture, sometimes due to associated factors such as even high IOP, high blood pressure, high intraocular pressure, or even rubbing can cause, or any Valsalva maneuver that causes the pressure in the small vessels of the eye to go up, they can cause this. Okay, so usually no need of any major treatment. Lubricant drops for 10 to 14 days. Sometimes it takes more than 1 week to settle, absorb. Okay. Right. Then episcleritis is this one, sectoral redness, and then the rest of the area is not involved. And this is not very painful. Mild pain, mild tenderness to touch, and the vessels blanch with phenylephrine. The injected vessels are superficial and they can be blanched. And they will last only for a short time, maybe few months. You have to use lubricants. Episcleritis, okay. Another picture, okay. So you have to differentiate it from scleritis. Scleritis is a dangerous thing. It is scleral inflammation with maximal congestion in the deep vascular plexus. You can see the deep vascular plexus are involved. And then there is pain, severe pain, significant ocular tenderness, then watering and photophobia, and the appearance also bluish red. So that is important. That is because the underlying, what is there under the sclera there? What should appear blue? Blackish blue.
Retina, melanin,
Yeah, well, the retina is transparent.
melanin,
Yes,
melanin,
that's right. Melanin pigment in the retinal pigment epithelium. Okay. So retinal pigment epithelium and the choroid. So they will show the blackness here. So mainly the sclera, what has happened is actually the sclera has thinned. So retina is underneath. So before the retina, there is choroid. So the choroid is slightly showing through the thinned sclera. So that is what has happened. So appearance is bluish red. Okay, that's more dangerous. You have to refer and we have to collaborate with the physician to give them immunosuppressants or whatever necessary. So these are pictures. Okay, scleritis. And they get up early in the morning with pain. Okay, right. Now the next important thing is corneal ulcer. Okay, so corneal ulcers can be bacterial, viral, or fungal or protozoan. Okay, so acanthamoeba is the one that is common in contact lens wear patients. Okay, and apart from that, conjunctival injection can occur due to mechanical factors or trauma, and also due to chemicals, so alkali and acid. What is the worst one? Is it acid or alkali? Alkali is worse. That is because when acid is there, it can coagulate and it stops there, but alkali will penetrate and damage. But anyway, if you damage the eye with acid, then it's really unrecoverable most of the time. But luckily, we are seeing a little less trauma these days with acid. Maybe people have understood that no point in harming others within the very short time they are living in this world. Okay, so this is the corneal ulcer, right? So this is the corneal ulcer. This particular area is the corneal ulcer, fluorescein stain. This is the typical fluorescein stain you will see. If you suspect a corneal ulcer, you can put this stain and see. It will appear greenish, yellowish green. Okay. So this is the cornea being opacified due to the corneal ulcer. What is this typical branching ulcer? What is it called? Dendritic ulcer due to herpes infection. Okay, and what is this called? What is this? This is pus cells. This is the ulcer. It has perforated. Okay, almost perforated. And this is the hypopion. Okay, so learn about that also. These are some more ones. This is herpes zoster. Okay, so uveal tract. Uveitis is also another cause, right? Then anterior uveitis and posterior uveitis we have to check. Then the last important concept is the acute angle closure glaucoma. You will do these things in later in detail. So aqueous drainage, produced in the ciliary body, ciliary processes, and then it goes through the posterior chamber, through the pupil into the anterior chamber, and then through the trabecular meshwork and episcleral venous plexus. Okay. You will have a lecture, separate lecture, acute angle closure, but I'm just touching here because it's one of the DDs in red dye. So what are the symptoms in acute angle closure? Severe ocular pain, headache, nausea, vomiting, decreased vision, colored halos around lights, and photophobia. Signs: semi-dilated or non-reactive pupil, ciliary injection. So the injection is here, ciliary injection, corneal edema, shallow AC, flare in AC, and raised IOP. Okay, right. So that's angle closure glaucoma. Okay, 2 minutes. So this is what you have to do now. Conjunctiva, pupil, cornea, anterior chamber, IOP. What will happen in different conditions? That is how you can differentiate a red dye. So subconjunctival hemorrhage, what will happen? Will the pupil be normal, cornea normal, anterior chamber normal, IOP normal? Conjunctivitis, what happens? Iritis, what happens? Pupil, small, fixed, irregular. And there are corneal dots-like things, precipitates. We call them keratic precipitates or corneal precipitates. Then the anterior chamber is turbid in iritis due to the suspension of white cells. In acute angle closure glaucoma, entirely eye red can be red, fixed dilated oval sometimes, cornea is hazy, and the IOP is high, stony hard. It goes up to 50-60 millimeters of mercury. So very high pressure. When you touch, you will feel that. Okay, so these are some of the differential diagnosis, how you can diagnose. Okay, right. We will have to stop there. Any questions you have? Yeah, the red flags with red dye, photophobia if it is there, pain if it is there with red dye, and reduced visual acuity. Always refer. Photophobia, pain, and reduced visual acuity. Always refer the patient. No harm referring because you can save the sight of that patient. Okay. Especially acute angle closure glaucoma, if not treated immediately, irreversible blindness can occur. Okay. Right. With that, we finish. Any questions?